Good afternoon, everyone. We're really excited that everyone can join us today. We're going to start with some quick introductions, and you may recall meeting each other during the kickoff webinar, but now we have formed the smaller work group. So here's our agenda for today. We'll do a welcome introduction. We're going to dig into the work plans a bit, and we know everyone spent a lot of time putting theirs together and providing comments to one another. We're going to hear presentations from Maryland and Age Options in Illinois. We're going to test out a peer consultancy approach where one community will share a challenge and then other sites will provide feedback. So we're excited to trying that out today. And so that's what we have lined up. To start with introductions, we want you guys, we'd like everyone to think about a theme song that expresses where you're currently at in your project right now, either the energy that you're feeling or the stage of work that you're in. So take a minute to think about that. And we will start with, let's start with Age Options.
Hey, can you hear me?
Yep.
Okay, great. Hi, it's Nikki from Age Options. Also here is Peg Tully, and Joan Fox will be joining us shortly. Our theme song, right? You said a theme song? Our theme song is "We Will Rock You."
Great. And why does that express the sentiment you're feeling right now?
It's our planning season, and we're just like gearing up to strategize and just take on 2019 with a renewed energy.
Great. Thanks.
Yeah. Awesome.
From Lutheran, can you tell us a theme song related to where you're at in the project right now, and then introduce your colleagues on the line with you today?
I'm thinking Rocky. We're on the bottom step, perhaps, or maybe the second step. We've got lots of energy, and we're charging ahead.
And then who else is with you with your team?
Let's see. I believe we have Shannon. Shannon, are you on? As well as Tim.
Great.
And Swati will be joining us shortly.
Okay. Thank you. And then from Maryland, Living Well Center of Excellence.
So this is Sue. I think we're going to start with "You Better Not Cry, You Better Not Pout."
Love it.
And why does that express the sentiments you're feeling right now?
Oh, I think we're feeling overwhelmed, to be honest with you, with some personal challenges, some challenges at work, and then just the whole season that comes down on us. We were hoping it would be a little quieter in December, but things are really ramped up, so we're busy.
Yeah. We feel you on that. Thanks for sharing, Sue. And then who else is on the line with you?
So I know Leanne is there. I'm not so sure whether Patty and Larry and Brandon are with us or not. I'm in a separate office.
Got it. It looks like we have Brandon on the line as well. And then from Oregon Wellness Network. Okay, go ahead, Lavinia.
I'm sorry, but I think I'm the only one that's here right now.
Hi, Lavinia. This is Lauren.
Oh, there's Lauren. Okay, great. So I don't know, in terms of theme song, we haven't really thought about that.
Oh, Kate says, "Get the party started" by Pink.
Right. That sounds good to me.
All right. Great.
Get the party started. All right.
Okay. And then Western New York Integrated Care Collaborative. We have Mary and Nikki on the line.
Okay, can you hear me now?
Yep.
Okay. The only theme song I can really think of is the Jefferson theme song where it goes, "Well, we're moving on up."
Yeah.
So that's what I'm feeling like.
Great. And why do you feel like you're in that space right now?
We're just moving forward, and we keep plugging along on all our different programs, so that's kind of how I'm feeling.
Okay, perfect. It seems like we have a lot of energy this afternoon, so that's great. Okay, we wanted to move on now and just remind everyone kind of the rationale for forming these two work groups. As a reminder, the materials for both work groups will be available in the on the online platform, so you're welcome to peek and listen to the recordings from the other ones. You're welcome to do that. We really took the feedback you guys provided from the evaluation from the kickoff webinar to heart and looked at the preferences for one-to-one peer requests and prioritized keeping those dyads together. So this group, a lot of you had pointed out that you wanted to talk with one another. So that was a big priority. We also noted that many of you operate as a network or a hub, and that there's also a strong interest in this group around billing and payment with healthcare and demonstrating ROI. So that was some of the rationale for putting this group together. We want to move on now and spend some time thinking about the homework assignment. So we appreciate everyone's effort on putting those together in a timely manner, and especially on the collective effort of looking across the work plans for each of the 5 sites and providing some comments. We had a lot of engagement there. And it definitely seems like some of the sites are in similar stages or have a similar approach in terms of thinking about how you want to move forward. I mean, definitely a lot of knowledge in the group to draw upon. So I think we want to spend this time now. I'm going to pass it to Lori, and we have some reflection questions for you, and we're really hoping that we can spend some time digging into some of the learnings that came out through that activity.
Great. Great. Thank you again, everybody, for doing your homework and creating the timeline or work plan. Again, we thought this might be a homework assignment that was an easy lift for you because you obviously have to develop a work plan when you're undertaking a project like this. And we want this also to be a really living document, an iterative part of your project where you're continuing to add more depth to the timeline and process and plan, to add more information as you go and you learn from other sites. And we also think that that you can continue to build out more detail in that to make it as useful as possible for you. So again, we appreciate you taking the time to do that. And we'd just like to know, how was the process for you in putting the timeline or the work plan together? Was it something you already had completed? Was it something new that your team did? So how was the process overall of putting that together?
Hi, this is Nikki. Can you hear me?
I can hear you, Nikki.
Oh, I was just going to say that preparing our work plan was a nice exercise. We had a committee do it, and it just gave us more clarity and direction on what we're trying to accomplish. So we enjoyed the process.
Great. And Nikki, I think we have 2 Nikki. So which site are you with?
I'm with Western New York Integrated Care.
Great, great. I thought so. I just wanted to make sure. Okay.
Sure.
So how were other folks? Anybody else in agreement that it was a useful activity, or?
Well, this is Sue. I think it was extremely useful, not so much in creating it is something we do a lot, but in seeing the responses and input from others was very helpful.
Wonderful. Good, good. So that was really leads into the next question. What did you learn or gain from either developing your own work plan as a team or from looking at others?
Hi, this is Nikki.
Hi,
from
Nikki.
Western New York. Hey, so what we gained, just like I was saying, just getting it more concrete, our plan, but also from others. I think it was Ken, maybe, I can't remember from where, that reminded us to ask. We're really in the heart of negotiations with a vendor to make sure, you know, some of the outcome analysis is already part of it before we sign on the dotted line. And I think I also appreciated that other people mentioned they were willing to share, you know, things they develop, which we are too, as we go forward in this collaborative. I'm really looking forward to seeing how everybody else, you know, goes about. It seems like a lot of us are doing similar work.
Great. And that's one observation that we made was that several folks are in their process of choosing a vendor. And I think the insight that you just provided around one of the key points that you want to make sure is included in your negotiations and your contracting is an important component that we can really learn from one another. So we do want to make sure on this call, near the end of the call, that we spend a little bit of time thinking through what are some of those really important components that we want to make sure are included or are thought about or discussed when we are selecting a vendor and prior to signing on the dotted line, as you mentioned. So thanks for sharing that, Nikki. What else? Other folks we haven't heard from yet, please share what you learned or gained from developing your own timeline and work plan or reviewing other timelines and work plans.
Hello, this is Alicia. Can you hear me?
Yep.
Okay, sorry, I'm confused here. I don't know if you heard our earlier comment that I think it helped us gain additional clarity on where we needed to think through in a little bit more detail from the work plan. So that was very helpful. Thank you very much.
Great, thank you. We appreciate that comment and hope that other folks reviewing were able to provide some insights that would be helpful in having you think through that. Thank you. Other thoughts about what was useful for you?
Hey, this is Nikki from Age Options. I think, can you hear me?
Yep.
Okay, great. I think for us, like Peg and Joan and I tend to be much more like in touch with the work and doing it on the day-to-day. And so I think for the other people on our team who aren't quite as in it, you know, thinking about partners and reports and those sorts of things, I think reviewing not only our work plan, but other people's work plan really help them think through some of the details that like we take for granted, that they may not think about as being important as we like choose vendors or negotiate contracts with healthcare providers.
Without putting you on the spot, can you mention any of those things that you were thinking might be taken for granted as you're thinking through that you would particularly point out so other teams can think about those?
Sure. So, for example, someone in their work plan mentioned talking to their delivery partners, so the people who conduct workshops, about what kind of reports they would be interested in and what kind of like data that would be useful for them on their end, which like we kind of on our level take for granted as like we talk to our delivery partners a lot more, so we know what they need, but people above us that may not be the case. So that was one, and what was the other one I was trying to think of? That's the one I can think of right now. I had another one, but it seems to have escaped me.
Okay. And we can pull the individual work plans up also just to take a quick look through these. So as other folks are thinking about observations, insights, it's great that not only did folks put them together, but you also spent the time looking at each other's work plans. So I'm just going to pull up the first one here, age options. And I might need to make this view a little bit smaller so you can see everything. Antonio.
I remembered it. So I was talking to Rob this morning about it, and he was saying that, you know, really thinking about like when you're choosing a vendor, thinking about the kind of reports you can pull, like the kind of data that you're going to need to answer questions from healthcare providers and other funders, and also like for your internal quality improvement, quality assurance, like what data you're going to need to track and what reports you're going to need for those questions. And so thinking about those before you sign a contract with a vendor, like thinking about like, can that vendor answer these questions for you?
Right. And one of the sort of pieces of the toolkit that we want to develop out of this learning collaborative to help others who will go after all of you have gone is a checklist of what those types of things are. So we're making note of the things you're sharing right now as components that you want to think about when you're negotiating your contracts with vendors. So that's a great observation. Anything else that you wanted to share? I'll pull up another work plan.
And Nikki, do you feel like you have been able, with your healthcare partners, to get a sense of what they need that's helping inform your decision around the report capacity of the system? Or are you just, how are you making those decisions, I guess?
Yeah, so when we negotiated our contracts, we tried to be very specific about what kind of outcomes and data they were going to want from us in the end. We also tried to be very specific then about what kind of information we wanted from them, and we tried to outline that in the contract. I will say, has been very challenging to get the health outcome data back from them. Like we were hoping for, we articulated that we wanted like 6 months outcome data from them related to things like falls and like visits to the emergency room when they had that information. We've had a really tough time getting that information for lots of reasons, you know, staff turnover, lots of different things. So yes and no, I guess.
Yeah, you had it there, but then they haven't been as responsive as you like.
Yeah, and I think, you know, it matters a lot who you talk to, right? So if you talk to the healthcare provider, like if you talk to the director of operations, great, but is that person the one who is looking at the database and can tell you how information can get pulled? Not always, you know, and like, is that person actually in charge of the person who needs to pull you the report? Do they have any pull? Can they tell them how to do it? You know, and so reaching the person at the right level and getting their buy-in and their commitment, and then not having that person leave in the course of a contract is super important and in many cases challenging.
Yes, absolutely. Because that data person really knows exactly what fields can be pulled and in what format, and maybe the director level person doesn't have that same knowledge, intimate knowledge.
Right, and yeah, and that person will be able to tell you, like for us, so I am the data person for our program, and so, you know, I can tell you that when you look at a list of completers for us, that is based on, like, the workshop starts on this day, not at the date the workshop ends, which makes a huge difference, especially if your year-end date is in August, right, which is, as we all know, the like height of workshop delivery time. So you really do need to get to that person who can give you the actual information that you need so that you're representing it accurately.
Yeah. Thank you.
Right now I have Lutheran Services work plan pulled up, and can't keep that up. One of the comments from Kate was, enjoyed seeing this in the work plan, such a diverse number of providers and partners. Change management will be crucial. And I appreciated Swathi's comment about looking for any suggestions on change management. And if that's something that you would like some information on, we can certainly include some information. Change management is going to be a critical component for you to think about as you roll out a new system and as you're making changes. So we can certainly provide some of that information in one of our full cohort webinars if you're interested. So let us know if that is a topic of interest, either through the chat or in one of your comments or on the evaluation. We are quantifying those things to see how many people are interested. So when we hear it repeatedly, we note that that's something that you want. I'll pull up another work plan, and we want to keep hearing from folks about some of the things that you're learning from reviewing work plans, some of the modifications, so that we can learn from one another.
I have a question.
Yes.
This is Lavinia with Oregon Wellness Network. It's been my experience in working with another system right now that we are, they're a vendor, that it often your contact is like the accounts manager who may not have a lot of technical knowledge about the system, and that when you raise issues, it feels like it has to be filtered through so many people before you get a response. And sometimes I'm just wondering whether or not it would be appropriate to just ask, can we speak directly to your technical people, because we don't get a response, we don't get the correct response, or we don't get an answer that satisfies the question. So we feel like sometimes this whole process takes a long time to just get a straight answer.
Yeah, I think that probably everybody can relate to that in some way. We've had a similar situation here with a new information technology system rollout, and having to work with the person who is either your salesperson or account type manager, somebody who is capable of helping you roll out testing and those types of things, but isn't the person working behind the scenes in programming, et cetera, and tailoring it to your needs. So it can really be challenging. So I'm going to turn this question back on the group. Who's had a similar experience, and have you been able to ask directly to speak to the programmers and the IT folks to ensure that your technical needs are being conveyed accurately and you're able to process those questions?
This is Tim Sheehan. Can you guys hear me okay?
We can. Thanks, Tim.
Great. I'm with LSSI, part of the LSA group. And yeah, I think that's always a big issue. I think a couple thoughts on that. At the beginning, I think that what we've tried to do is make sure that, and I'll just use like a managed care company as an example, that you have the different sectors: utilization management, care coordination, contracting, and even up the food chain, to have some level of contact and secure that at the beginning, because ultimately it has to get run through all of those groups, let alone legal and other entities. So trying to get that up front in a really kind of collaborative manner, in a friendly manner, before things go a little bit sideways. That's one thought. The second is, we have found it helpful to kind of think of these things as kind of almost think of it like the first contract as a phase, trying to start with a very simple contract, even when it's the thing we want to get to is much bigger, so that we can start to understand the organization and map out for ourselves how we're best going to engage the various parts of that insurance company, so that by the time we get to something that really is more of a priority for us, we're warmed up to that organization, because sometimes you really don't even know who to talk to unless you start to engage them. So those are two things. It's either get in there early with the request, or try a pilot or some sort of engagement technique to get to know them.
Great, thanks for sharing. Others?
Hi, I just wanted to say, as we look at this work plan, I think it's a constant struggle to find the needs of like a community-based organization comparing to what your clinical partners need and be able to get all that information back with just one IT system. And I think that's what we're struggling with, is the type of system that is going to happen that is going to meet all of those benchmarks.
And how are you managing that challenge?
We have actually, we're looking around and finding out what resources are there. I've been in a conversation with Harry Rogoloff, who is from the Maryland Department on Aging, that has done some work for CMS, and he's done some of this kind of the IT work before. So looking to pick his brain and working. Brandon's doing a great job on the community-based side, but we've got to be able to link that to the clinical side and get that information back bi-directionally.
That's great. And as you're collecting that information, if you could think about how you could continue to share that through the collaborative, I think that would be really insightful for folks.
But I'm just saying that's the constant roadblock that I think that's why we're also trying to work through our clinical teams and our partnerships, because we know there's something out there called Community Connect through the electronic medical record that the hospital has, and that's EPIC. And so how do we get able to do that? So I mean, that may answer some of our questions on the clinical side.
And does anyone else on the line have experience using Community Connect from EPIC? My understanding is that that's a newer feature that they're offering.
The feature that is offered through community or through that electronic medical record, but the hospitals have to purchase that arm of it.
Right. Yeah, and they have to be with the EPIC.
That's correct.
Mm-hmm.
And a lot of hospitals in Maryland are on that. So.
Well, that's great for you. Yeah.
Because I don't think there's any way that we can afford a system without making those kinds of collaboration that we could ever afford.
Mm-hmm.
All right. I've just pulled up the Oregon plan, if there's any comments or feedback here.
Kate or Lavinia, do you guys have any reactions you would like to share about the feedback you received?
This is Lavinia, and I was just sort of looking at some of the other ones that you had brought up earlier. A lot of what we have to do, because we're a hub and we're working with at least 16 partners, is that we have to pass any ideas and plans past our exec committees. Is this something that other agencies are also having to do? Because it certainly does put an extra layer in there and extra time that we have to allot for. Is anybody else facing that?
Lavinia, this is Nikki. Yeah, we're doing that same thing. We're kind of going from the perspective of, since we're the hub, we're doing all the vetting, but a lot of our network partners are involved in our They're invited to, look at the demos, things like that, but they're open to letting us kind of take the lead, and then we'll train them on the other side.
Well, that's interesting. So they're letting you make the decision, and then later you'll do the, I guess, updating them. Is that it?
And that's Nikki from Western New York, correct? Not Age Options?
Yeah, right. Sorry, I keep forgetting. But they're invited to participate in that decision making if they want to, because we let them know when the demos are and things like that.
This is Tim Sheehan. We're involved in 2 networks. One is a for-profit with about 30 members, and that's more centralized. We're not the lead. We're one of the owners, and that has its set of challenges, but the way that they address it is through structured committee work, trying to focus in on communication between board and committee to move things forward. And that does present a lot of challenges. And then the second group we're a part of is 12 owners. That's a not-for-profit.
Tim, your audio is going in and out. It was really strong, and then it got really weak.
Okay. I'll start back. Should I start back with, is this okay? Is this better?
Yep.
Great. The second group we're part of is in a network is 12 organizations, and we all have equal kind of input into something, so there's no lead. And the way that we've done it so far is to just vote by board to identify, is it going to be 1, 2, or 3 organizations. We try and then take the lead of those organizations and drive communication out to the others and allow those groups to lead the discussion. But that, of course, that leads to some challenges, but works pretty well, pretty effectively. So those are our 2 networks that we're part of besides our normal contracting.
So the for-profit group, can you explain again how you make?
So we have a newly hired CEO, and that person, if there's one, of course he's the point, but I think that there's a good deal of work of trying to improve communication between 3 committees that look at content. So whether it's the IT or finance or clinical, and those groups push information to the board and the board back to the committees. And the CEO is, ever increasing, having a role in making more and more of the decisions as appropriate. But really that's how it's been working, is to look at these groups and say, okay, how are we going to get 30 different organizations on board for X, Y, or Z contract? So it also should put in there that they've used extensive amount of consultants to help facilitate that communication, because it's obviously pretty clunky to have that many groups in an ownership role. So again, the CEO has been stepping in more, but it's board and committees.
And the 3 committees were?
Finance, IT, and clinical.
Lavinia, at Western New York, we also do committees. And we have quality assurance and IT committee, and then we have a compliance committee and a finance committee and an emerging business committee. So all of the IT stuff gets discussed pertaining to which committee it falls under.
Interesting.
So we're going to move on to the last work plan, the Western New York work plan. Thank you for that discussion and sharing. That's exactly what we want to happen. If there's any feedback, or Western New York, if you have any observations or reflections based on feedback you got, or in looking across the work plans, we'd love to hear it.
I think ours is just very similar to, you know, Oregon and to a lesser extent, maybe Maryland. But just trying to finalize our contracts and then move forward and then try to get that integration with the providers. And an area that we've kind of mentioned as our third goal is how to use the data, you know, once we were collecting it. So learning from the collaborative kind of best practices for using the data, and making sure we're collecting the best information for providers. And I mean, we know what HEDIS scores to look for and things like that, but just any suggestions that the collaborative has found in their work.
Okay. Well, if you have any, they might follow up after Marilyn's presentation today. So we will move on into back to the presentations, back to the program.
Great. So we are going to pass it over now to Nikki at Age Options. Or no, first we have Marilyn.
Yeah.
So Sue, this is you. I mean, we've budgeted about 10 minutes for the presentation and then 5 minutes for discussion or questions after that.
So I think we'd like for Leanne to chime in, but I thought that you all would be interested in, so CRISP is actually our health information exchange in Maryland, and CRISP stands for Chesapeake Regional Information System for Patients. And it is so widely used throughout the healthcare field that they refer to patients as being crisped. So that's the reason, that's the title here.
Well, it
has to do with the intake and the tracking. Leanne, is your line open?
I think so, right? Yeah.
Sure. Good. So why don't you go ahead and I'll chime in as needed.
And I'm advancing your slides here, so if I don't advance soon enough, let me know and I'll make sure to adjust.
Sure. So let me just quickly say that for those of you who may not be familiar, and if you're all familiar with an HIE, then we can skip this slide altogether. But I did want you to understand the value of this kind of an entity. They're a key collaborator with us, and of course you can see below their core functions include their clinical query portal, their care coordination, outreach, so that allows them to contact any care providers who are linked to that patient in order to provide them updates on their, if they're in the hospital or whatever. And then because we are that single payer state, that whole idea of population health and really critical components around performance measurement, so on and so forth. And then you can see a final piece that they're doing and assisting with at the hospital level, as well as our providers are all going on total cost of care in 2019, so they can assist with care redesign. So next slide, and Leanne, you can take it from here.
Here's what we see is the HIE and the partnership is the data sharing. And it's our way to track health, hospital-specific outcomes, cost savings, the data sharing agreements. We basically look at like chronic disease self-management, diabetes self-management, our pearls, stepping on, and we put them in what we call a profile. And then we are able to submit those profiles to CRISP and find out whether those people have been in the hospital or the ER. So that's how we can demonstrate our ROI. And I think we began to get this understanding as we were part of the n4a learning collaborative, where we actually looked at, in Maryland, we saw, well, we put through 1,100 people in the chronic disease self-management program and diabetes in 2017. So we looked at national hospital data of ER and hospitalizations. When we did that, we saw we saved the state like $1.74 million. So with that being said, we said, wouldn't this be great if we couldn't demonstrate this with each of our 26 healthcare partners, what their actual cost savings is, because then we can demonstrate what these programs can do for them, these EB programs. So with that being said, thanks to Sue, the evidence-based program got written into CRIS, which, by the way, Sue said would never happen, but it did. But so we actually have an MOU with CRIS, and we are working through the challenges of, we're getting the profiles in there for the challenges. Now we're slowly being able to figure out how to get that information back out. But I think you can see the value. We can also put in what we call a care alert, which means if someone comes to a class or we're out there doing a one-on-one pro visit and we find something like they don't know how to take their insulin or whatever it may be, we can put in a care alert into CRIS. And the doctor, now we would also follow up with a phone call and not totally rely on that at that time. But that is the benefit of a care alert. Next slide. Here's the my future efforts in Maryland with CRIS is we're working to get a standardized social determinants of health and a questions of risk assessment. We're striving to get a central tool, a tool that's the same, because there's so many different surveys out there for the social determinants of health, and we know what a large role that social determinants of health plays in keeping people out of the hospital and the ER. We plan to document services provided to mediate risk. We want to cut the risk. Maryland, we're on a single payer a budget or a global budget, so it's very important to keep people outside of the walls. So taking care of the community level is very important. We hope to demonstrate the value of non-clinical services and to improve quality of care by getting the like ramps in there, by getting a Meals on Wheels, by looking at the social determinants of health, by looking at those kinds of factors play a huge role. Next slide. You know, the HIE and the opportunities with its CBOs as other states begin to move forward, and the population health arena measures the value of services provided to the by the community-based organization will increase.
Yeah, and this is Sue. I wanted to add, you know, Leanne is right. CRISP has really become a valuable partner for us. We have done any number of presentations where we've been on panels together at conferences, and as Leanne indicated, we initially, or my first thought was that, again, they were working with the hospitals. We were a little single, a community-based organization, and Leanne fought her way to making sure that CRISP understood the potential value of the Living Well Center of Excellence. But clearly, because we have this population health focus, CRISP and others are seeing more and more that they have to partner with community-based organizations. And so this opportunity, anytime we reach out to them and ask them if they will appear with us on a panel or on a webinar, they've been very willing to do so, because they do realize that we all are going to need to work together in order to maintain and lower healthcare costs and really improve quality of care.
I think too is you need to realize the hospitals actually pay for it, so those relationships are very critical to like the hospitals, because they actually have to ask for it. So that that ask piece has to come from them.
Are you saying that the hospitals have to pay for the community-based programs? When you say the hospitals have to pay for it?
Hospitals pay for CRIS.
Oh, they pay for CRIS.
Or they pay for the HIE. They pay for that exchange system. So in order for them to do something like they had to do with us, the hospitals had to say, I would like the Maryland Living Will Center of Excellence to be able to do X, Y, and Z, like be able to put the profiles in, be able to put the care alerts in, because they're ultimately paying for that service.
Great. Thank you for clarifying that.
This is Tim Sheehan from the LSA group. Can you guys hear me?
Yes. Yes.
Great. Great presentation, and it's for us in Illinois, it's very hopeful to see something like this operating and doing well. It seemed like it's kind of maybe coming in phases. Have you guys dealt with, in terms of behavioral health, the substance abuse issues, the federal rules on confidentiality or HIV or any kind of specialty confidentiality? Has the group dealt with that, or is it more on the right now operating more from kind of a health hospital perspective?
We don't see things from the behavioral side. So we are able to document into CRIS. We cannot see anything.
Thank you.
Hi, can you hear me? This is Shannon McKenzie, also with Lutheran Social Services and Simply Connect. Can you guys hear me?
Yeah.
Okay, great.
Yeah.
Thank you. Wonderful presentation. There's a significant amount of similarities with some of the projects and collaborations that we have going on with Lutheran Social Services of America. One of the things that I was wondering if you guys have thought about what it would look like to involve the patient in the exchange of information. A lot of the information that you provided was with provider to provider, but just curious if you guys have thoughts or have things in the works as far as activating the patient and having more ownership with the patient, having access to their individual health information.
So this is, we're not really sharing any patient health information. Right now what we're doing is submitting attendance, participation in the evidence-based programs. We are working directly one-on-one or in small group with clients or patients. And so all of those programs are really around skill building, empowering the patient, but we don't collect, nor do we see the actual health records.
Thank you for that clarification.
This is Tim Sheehan again. In terms of going back, I think a couple slides, I thought I saw like there's a pinging or some sort of notification for ERs. How real time is that? Like, for instance, if somebody came in now, when would that be posted that they hit the ER?
Well, the system, any system is only as good as the data that they're getting. The benefit here is whenever that does get entered into CRIS from the hospital side, it can be pushed out to anyone who's identified as one of the care coordination organizations who is working with that patient or client. And CRIS goes so far as to literally tailor those care alerts based on how the care coordination folks want them. So it could be emails, it could be pushed to a text, it could be done once a day, it could be done in a list. They have several methodologies that they really are trying hard to make sure they fulfill the needs of the folks that they're working with.
That's great. Thank you very much.
If there are no further questions, we'll move on to the next presentation. Any final questions?
This is Anna. I had a question around I think this came up with around what kind of health outcome data folks are getting back from healthcare. And you guys mentioned you're able to get utilization rates. Is there any other data that you're able to get back from CRISP? Health outcome data?
We haven't really looked specifically at anything else other than this at the present time. I think as we move into the total cost of care model with providers, we'll be looking for additional health reports.
Okay, great. Thank you. Okay, we're going to pass it now to Nikki at Age Options.
Hi, everybody. This is Nikki Briggs from Age Options. Also in the room with me is Peg Tully and Joan Fox. I've been here about 3.5 years since we got our first ACL grant, and we run the program called, we call it Illinois Pathways to Health. And so most of the questions that were posed to us were mostly related to our clinical community linkages setup. So that's kind of what we're going to cover. And yeah, there we go. So we want to get started with the structure. So just to give you an idea of how we have it sort of organized here, so Age Options runs Illinois Pathways to Health, but we are also a delivery partner within the system. It's a little bit meta, but so Illinois Pathways to Health is the statewide delivery system for evidence-based programs, and Age Options functions as one of the delivery partners within that system. So you can see on this slide, other delivery partners might be other AAAs, YMCAs, a variety of other people. And then mostly within the Chicagoland area, we work with traditional partners like libraries, senior centers, and then some, quote, non-traditional partners. We have some workshops that are happening in correctional facilities, and then what we're focusing on today, which is our healthcare providers. Yeah, great, thanks. So we were asked to discuss how we connect with healthcare providers and how they refer clients into into the programs, and then how those are executed by the CBOs. So we traditionally have two types of referrals. One, which is on the top, which is the point of care referral. So a healthcare provider who has been trained by our program coordinator here at Age Options is in a regular meeting with one of their patients, and they think, this person's A1C is consistently above 9, and then they would generate a secure email, a secure message to Age Options, and we would receive that immediate referral. So in that case, we would try to slot that person into a workshop in and of itself. The second way that we get referrals from healthcare providers is via the panel referral process. This, to be honest with you, is our preferred way of receiving referrals. So we meet with the healthcare provider and discuss the metrics, the health metrics that make the most sense for people to get into either a CDSMP or a DSMP program. Here we call them Take Charge of Your Health, Take Charge of Your Diabetes. And then they use that information to pull a panel of patients. So anyway, we ideally would get at least minimum 400 people. We have gotten them as small as 80 people, but it tends to be pretty difficult to fill a workshop with such a small panel. So we get that information, they send it to us via secure email. We house it in our HIPAA compliant data management system. Okay, and then the next slide. So then it's pretty much the same after that. For both of those referral processes, it pretty much falls into this general system. So our age options coordinator or one of our community health workers who's been trained in motivational interviewing and speaks the language of the client calls the patient. So we will have negotiated with the healthcare provider the number of phone calls that person will receive and the number of contacts that are required. Then, ideally, assuming all of the information is correct, including but not limited to like their phone number and that they actually have the condition that they are supposed to, that they, that we were told that they have, that they are, that they speak the language, like any of those things, then that person will hopefully be enrolled in a Take Charge workshop. And at that's the point where we would collect their pre and post information. So we collect everything. So before, like for a while, we had a pretty standard data collection tool. In the past couple of years, the past like a year and a half probably, we have, the more that we've had conversations with healthcare providers, the more we realize that they're not always interested in the same things. And so for some of those places, we need to customize our data collection tool, which, to be honest, is kind of a lot of work to create the tool, but then also to train our facilitators to administer the tool, the different tools. That's a challenge that we have. And then it has to be housed. It has to be, like, data has to be entered, and then it's inconsistent across all of them. It's not ideal, but we also always want to keep in mind, like, the burden of participants filling out data. Lots of pieces. So the kind of information that we collect, right, is obviously the basic stuff like attendance and health confidence, but then we also look at like how many times they report that they visited a doctor, hospital emergency room, been hospitalized overnight, things about health literacy, like do they ask questions of their doctor, do you prepare a list of questions before you meet with their doctor, anything that would indicate patient activation in a pre or post situation. Right. So then we would share. So we would share that information back to the healthcare provider, where possible, in whatever way that has been deemed appropriate based on the contract that we have negotiated with them. But always, obviously, in a HIPAA compliant manner. And then what they do. Yeah, I'm still on the slide with the circle. Yeah, I'm on the 1, 2, 3, 4, the fifth box, the one that's like 8 o'clock. So the clinic champion then distributes that, and they do whatever they do with it. Ideally, that information gets back to the healthcare provider, the PCP. That's not always the case. We can only do so much education in that regard, and they're going to do whatever they want with it. Yeah, and then we hope, that they will do follow-up and goal setting and all of those things that keep patients engaged. And then the cycle basically starts over. So some of the questions we were asked about this. So we currently hand enter all of the panel referrals and the point of care referrals. We are looking at a way to directly import that information into our data management system. As I'm sure all of you know, that can be kind of costly. Like, I'm a pretty tech savvy person. Like, I love IT and data and our data management and like managing data, but it's a lot of work to prepare data and clean data and make sure that it gets massive amounts of data gets imported correctly. So that it basically gets entered by people who have been trained explicitly for that service. And then as it stands right now, basically we are the only ones who can pull reports, mostly me and Joan, and Peg is getting trained on some of it. Ideally, we want our program coordinators across the state to be able to pull their own data. The data management system we currently use is not super user-friendly and requires a lot of training up front. So that's one of the things we're looking at within the collaborative is how we can find a system that is more user-friendly and intuitive to use. Yeah. Okay. So one of the things we planned into our second round of ACL funding was a systems level evaluation. So we contracted an evaluation team out of the University of Illinois Chicago, and they have for the last year been doing interviews with people at various levels of our system. So program coordinators, facilitators, age options board members, healthcare providers, age options staff, all those people. And they have started to find, like they have reported some findings to us. We aren't expecting, we had hoped to get recommendations next week. It seems like we're going to be getting them probably next month. So we'll be happy to share those when we get them. The findings so far are much more related to like an inconsistent vision for where Illinois Pathways to Health is going. So, you know, Illinois is a really large state. There's, you know, keeping like technical assistance and communication for more than 26 delivery partners is pretty challenging. And so people don't always share the same vision for what the program should be. And that's one of the things we're working on moving forward is articulating really clearly where we're going and what it means for people to get on board and what they need to do to be able to be a part of where this is headed. So like I said, yeah, recommendations, we're expecting those next month from the evaluators, and then I believe Rob will be happy to share those with you when they come out. And then, yeah, our goals. So you saw our goals in our work plan. You know, many of our delivery partners across the state have various levels of technology within their offices, and so we would love to find a way to manage data that's not on paper. Like currently, the HIPAA compliant manner that we are sharing participant evaluation data is mail, like U.S. postal mail, and that's slow and kind of cumbersome. And so we would love to find a way to get people to be able to share that data more easily without putting a significant burden on our already understaffed delivery partners across the state. And then, as I mentioned earlier, like one of our other struggles and goals moving forward is to be more stringent, or I don't know, forceful is maybe the right word, but demanding in getting our healthcare outcome data from our healthcare providers. That was articulated in the contract, because we all know that like that is the information, like that cost savings that Marilyn was talking about is crucial to being able to secure further healthcare provider funding. And unfortunately, we don't have a health information exchange, so jealous of you. So those are our goals, and yeah. Thanks very much. That's our last slide.
Thanks, Nikki. I was going to ask you how that process works in terms of how the data is shared back with your healthcare partners, and you just said it's by mail. So it seems like there's lots of room to go up.
Well, that's not, so we don't share it back with healthcare providers that way. Like them, we will share it back with them through, like we send them, like they have secure systems for us to email into, but our delivery partners don't.
Okay.
So they mail, like when a workshop is completed, they mail us the paperwork. We input it into our HIPAA compliant system, and then we can, you know, generate an email here that's secure to a system that's secure at a healthcare provider's office. But our CBOs don't have that capability.
Got it. Thank you. So I want to open it up to the rest of the group for questions for Nikki.
This is Lavinia. You know, on that secure email, what we found is that, yeah, a number of our providers or our CBOs don't have secure email, but if we send them a secure email and they reply within the secure email and attach their data to that, it's one way we've gotten around that problem so that we didn't have to use secure fax or U.S. Postal Service. So I don't know if that might work for you.
Yeah, that might work. My question then is, how are they storing the paper files? Like, are you at all concerned? Because I guess this has been my concern, right? Is that they aren't as an agency HIPAA compliant. They're not prepared for the responsibilities of HIPAA. So I guess we have been hesitant to ask them to store PHI at their office. Or do you just recommend to them that they shred it?
Well, they need it until they, you know, they'll need it at least until they're finished doing whatever, you know, course they're doing, because we have them submit their data right after the classes. Would be, we just, you know, in terms of HIPAA, we do actually ask all our providers to go through HIPAA training, and so we talk about where they're storing their data, and it's behind, you know, make sure it's behind 2 locked, you know, offices or you know, storage devices. So that's the way we've addressed it, and I don't know if that answers your question.
Yeah, that's helpful. Thank you.
Other questions?
Hi, this is Nikki from Western New York. Can you hear me okay?
Yeah.
Okay. Just to piggyback on the HIPAA question, we're wondering this right now. As you set up your classes at the community site, are you having the community site staff take HIPAA training? Because, you know, they're maybe signing Mrs. Jones up for a diabetes class. I know this doesn't have to do with maybe their electronic health information, but the fact that, you know, they're having them come in and then talking about possibly the fact that they're taking a diabetes class. I'm just curious if anybody's come across that.
We have all of our facilitators who will be interacting with participants of a Take Charge of Your Diabetes workshop complete a HIPAA training.
Okay, well, we have our peer leaders, for example, they all take it, but I'm talking about like the library staff where you're having the class, you're hosting it in the library. You know what I mean?
Oh yeah, we don't worry about them because I think so. We've talked to our legal department about this, and so I'll give you the line, which is that as an agency we don't provide HIPAA information to advice to other people. So I put the disclaimer out there. But what we do is like it would be the same as if anybody signed up for any other workshop. If they wanted to disclose, like they may not have diabetes, they may be taking it because they're a caregiver for someone with diabetes. And so we kind of get around the issue that way of like they're not associated with a healthcare provider, so it's not officially healthcare information. Health is like PHI, and then therefore not really protected under HIPAA.
Okay, that makes sense. I mean, I'm definitely going to run this all by our attorney, but I was just curious of what other people did.
Yeah.
Thank you.
Great questions. Any other questions? Okay. Well, our next step in the webinar that we had planned to do was a peer consultant model that we've used in a lot of different trainings, and particularly in classroom, or a lot of different workshops, particularly classroom workshops. So this was going to be one of our first times trying it out virtually, although we've been participants in it virtually. we're not going to have time to do it today, but we wanted to spend time explaining it so that you know that in future webinars, it's going to be something that we're doing. So what we will do in this model is after you hear community presentations, or you may hear an expert presentation, or we may be talking about a particular topic. Someone who has a challenge that you're currently dealing with or you are anticipating dealing with, you will take a few minutes to describe that challenge to the rest of the group. So you'll give us the information that you think we need to all know to help give you some ideas for solving or working through that particular challenge. So you'll take 3 to 4 minutes, or no longer than that, but if it takes less time, that's great, to describe your challenge. Participants, all the rest of us on the line, will have a little bit of time to ask you any clarifying questions about that to make sure we have a good handle on what your situation is or what the challenge is. And then for the next maybe 5 to 8 minutes, we will contribute ideas to solving that challenge. So during that time, anybody's team who has experienced that challenge or has been anticipating and preparing for that challenge, you'll share some ideas related to how you have prepared for that, addressed it, experienced something similar and what you've done, or just some ideas that you have for things that the participant who's having the challenge might consider. And then we'll take a minute just to summarize those ideas so we can document that and share that with the other group or for others who come after us in dealing with this. So this is a great model to get the best minds all working together on a particular challenge and be able to collectively solve it. It's really the essence of what a peer learning collaborative is all about. And this is the model that we'll be following in upcoming webinars. So as you are listening to presentations in the next webinars, or we're discussing a particular topic, or we have an expert speaking, if you have a challenge you're experiencing, or you also are going through the time between webinars and a challenge is coming up, you can submit that challenge to us prior to the webinar and let us know that you have one you'd really like the group to work on, or you can submit it at any time during the session through the chat log, and we'll be prepared to choose you. But it would be great if we can sort of get any ideas on starting those out so that when you have them, we can prioritize them and make sure that they get addressed through the webinars. So that's one of the next activities we're going to be doing in future webinars, in addition to similar presentations where we ask teams to present on a particular piece of work that they're doing. The Q&A that you shared back and forth was great. I think that was really helping each other understand both the challenges, but also how you've been dealing with some of those, so we love that. And I'm going to turn the webinar back over to Anna just to close us out.
Great. Thanks, Lori. So I think in terms of next steps here, we have a slide up on the All-In platform, and I've mentioned this is a good space for, I feel like there were some questions that came up today that are still, to be answered along the course of the Learning Collaborative. So this could be a space where you could post that question. It would get seen by everyone in the full Learning Collaborative, not just the work group. But also at the top there, there's I think it's under activity feed, there's an open forum discussion. And that's another space where you can start a new thread and say, has anyone, in this network used community connections from EPIC? And any other questions that you have like that. I think we can also work on compiling the questions that are coming up from these discussions, and we'll post them here in the N4A space. That way, if you come across a solution or a resource, you can respond there. The other thing to note is that we have our, you can advance it to the next slide. We have our next full cohort webinar, which is coming up soon. This is in January on the 9th. And we'll be sending materials out for that soon. We're also very close to having a concise project profile for each site that'll be available in the online space as well, just as a reminder for you to go back, who's doing what, and we will have a few pieces of that profile that we still need you to fill out. So one request that has come up is a list of which softwares folks are using for different programs. So you can list, we're using this tool for our evidence-based program, we're using this tool from the state for this program. That's something that everybody would like to see. So that way you can identify if anyone else is using Workshop Wizard or PeerPlace or some of the other tools you guys have mentioned. So we'd love for you to take a look at that and just kind of sign off on that profile, fill out the additional information, and then we'll make them available in the platform. Lastly, we have a evaluation that'll pop up here right as we close out, so we appreciate you guys taking the time to fill that out.
When that evaluation pops up, there will be one question that asked how effective the peer consultant portion of the webinar was, and since we didn't get to do that today, you can skip that question, but that will be a part that we're going to include in future webinars.
So Antonio, this is Sue. I just want to make sure that you also have the ability to collect some of the chat that was going on. If people were taking a look at that, there were a few questions and answers there as well.
Yes, we have a copy of it that we pull after each webinar, and we can share it.
Great, thanks.
Were there any questions or answers we want to highlight and pull out right now for folks?
This is Nikki from Western New York. I'm just wondering, are you going to send an email that gives us a link to tell you what software everybody's using?
So that profile, okay. I think we'll probably do it as maybe as a Google Doc again. But Antonio will send you the profile. It'll be mostly populated with information you have already shared from the kickoff webinar, the application, and the one-on-one call. But we've identified some new bucket areas where we don't have that information from all of you. So that would be a place for you to fill it out. So it'll be a Google link.
And if we've put something in and we've misrepresented it, you can correct it through comments or track changes.
And you're more than welcome to add additional information to them too. We just didn't want it to be too burdensome, but more of a reference or a cheat sheet so that we can all keep track of who's doing what. Great. Well, thank you all so much. We really appreciate your time, and it was good to get to know some of these projects a little bit more.